Hey guys, welcome and welcome back to my channel. This is Dr. Prasanjit Das, currently JR1 in the Department of Pharmacology, AIMS Kalyani, and I am back with one of my seminars. So without wasting any time further, let's get into today's topic. So today I'm going to discuss about the topic that is modeling in pharmacology. So this is one of my seminar topic. So in this presentation, the topics which we are going to cover will be including the introduction to the modeling in pharmacology, the definitions related to modeling in pharmacology, then classification of the models in pharmacology. Under that we have the pharmacokinetic models, that is PK models, then pharmacodynamic models, that is PD models, and then the integration of pharmacokinetic and pharmacodynamic models, that is PK-PD models. Then finally coming to the applications of PK-PD models and the different softwares which are used in PK-PD modeling. So a little mention about the softwares which are being used for PK-PD modeling. So coming to the first slide, that is introduction and definitions. So we know that we need to do the rational use of drugs, and we should always design an effective dosage regimen for doing the rational use of drugs, and this can be possible only when we can appreciate the relationship between the concentration of the drug, the dose of the drug, and the effect which is produced by that particular concentration in the body, that is in the body fluids, which can be measurable. So this is basically the interaction of the pharmacokinetic properties and the pharmacodynamic properties. So what are those three things which we are considering here? We need to know the relationship between that. Is first is the dose which we are administering, next is the concentration that it produces in the body fluids which can be measured, then third is the effect which is produced by that particular concentration. So they are So this is where the pharmacokinetic and pharmacodynamic modeling comes into play, that it helps us to understand the relationship between the pharmacokinetics and the pharmacodynamics of a particular drug, and it combines basically both the properties, that is both the pharmacokinetics and pharmacodynamics. So before we go on to the definitions of pharmacokinetic models, pharmacodynamic models, and the integration of those, we need to know what is a model actually. So model in general actually means a very simplified description of a true biological process. The true biological process means the pharmacokinetics or the pharmacodynamics, that is absorption, distribution, metabolism, excretion, then the drug receptor activity, and the production of the effect. So models are basically the description of this true biological process, and it helps us to do the data reduction. But the major application of the models is that it helps us to extrapolate the relationships beyond the existing data. So we will be having some sort of data, that is which we are getting from the study, that is either it is the pharmacokinetic data or the pharmacodynamic data, that is the intensity of the effect or the concentration of the drug in the blood. But from that we will be able to extrapolate other details also. That is the advantage of using the models. So this is what we call the modeling in pharmacology. Now coming to each of the models individually. So first we have the PK model, that is pharmacokinetic model. So pharmacokinetic model basically describes the time course of concentration of a particular drug in the body. So it will be basically describing about the concentration of the drug in the plasma, because that is the one which is easily measurable for us. So here you can see the time course of drug concentration in plasma or blood. So here you can see the graph for pharmacokinetic model. So as you can see, when we are giving a drug, initially the drug is getting absorbed. Okay, so suppose let's take a consideration that we are not giving the drug by intravenous route, because in intravenous route there is no absorption, that the drug directly enters into the blood circulation. So here we are giving a drug that is by a route which is not intravenous. So what happens is that initially there is an increase in the slope, that is the graph is going upward. This is because there is increase in the concentration as the drug is getting absorbed, and later on the drug is being used up and it is getting distributed from the plasma, so the concentration decreases as the time progresses on. So this is the concentration time graph which is pertaining to the PK model. That is the pharmacokinetic model. Next, coming to the next one, that is the pharmacodynamic model. So pharmacodynamic model actually describes the relationship between the drug concentration at the site of action. Okay, drug concentration at the site of action, also the drug concentration which is present in the plasma. But to be specific, we have to say the site of action and the effect. That is, it relates the concentration with the effect. So here you can see in the x-axis we are having the concentration, and in the y-axis we are having the effect. So here you can see that it is a sigmoid shaped curve, that is for a particular drug. So it explains that as the concentration of the drug is increasing, the effect increases, and to some extent when a particular concentration is reached, we get an Emax, that is the maximum effect which can be produced by that particular drug, and then the response doesn't increase much even after increasing the concentration. So this will be a case of a drug where it is producing the effect by binding to some of the receptors or the ion channels which get saturated at a particular concentration, and then this is going to lead to an effect which will be having the same intensity later on, even though we are increasing the concentration of the drug. Now next comes the PK/PD model, that is the combination of the pharmacokinetics and the pharmacodynamic model. So here you can see on the y-axis we are having effect, and in the x-axis we are having time. So initially, that is initially when we are having this graph, that is the starting point. So at the starting point, what we have seen is that in time 0 and or after some time at time 0 or little bit after that, we can see that there is an increase in the concentration. Okay, here you can see that is the drug getting absorbed into the blood vessel, and for an increased concentration from this graph we are having the maximum effect. So initially you are getting a maximum effect at a particular time, and as the time progresses, here you can see as the time progresses the concentration decreases, and when the concentration decreases the effect decreases, and as a result there is a downward slope. So this is the interpretation of the PK/PD model that is obtained from the PK model and the PD model. Now coming to the classification of the models in pharmacology. So first we will be classifying the PK models, that is pharmacokinetic models. So in this we are having different models, out of which the most commonly used one is the compartmental models. Then we have PBPK model, that is physiologically based pharmacokinetic models. Then we have non-compartmental analysis, and finally we have the statistical models. Now further, this compartment model, there is the compartmental model, is divided into different types of models. First is one compartment model, then we have two compartment model, and then we have the multi-compartment model, that is comprising of more than two compartments. So the multi-compartment models can be of two types. Either it can be mammillary type of model or it can be catenary type of model. So the details of these type of models will be discussed in the upcoming slides. Now coming to the next classification, that is the classification of the PD models, that is pharmacodynamic models. So under this we have broad classification, that is the models which are simple and steady state. Okay, so it is related to the steady state concentration of the drug. So simple and steady state models, and then we have advanced and non-steady state models. Okay, so under the simple steady state models we have the different varieties. First is the fixed effect model, then we have the linear model, then we have the log linear model, then we have the Emax model, then we have the sigmoidal Emax model. And under advanced non-steady state models we are having different types, that is the biophase distribution model, then we have signal transduction model, then we have the tolerance model, and then finally we have the indirect response model. The details will be discussed in the upcoming slides. Now coming to the last classification, that is the classification of the PK/PD models, that is the integration of the pharmacokinetics and the pharmacodynamics. So under this we have different types of models, that is it is basically contrasting two types of models. So based on the link, it can be either the direct link model or it can be indirect link model. Based on the response, it can be direct response model or it can be indirect response model, based on the type of relation between the concentration and the effect, that is whether it is bidirectional or unidirectional. In that case we are having two different types of models, that is soft link model and hard link models, and finally time variant and time invariant models. So these are the different types of models which are coming under PK/PD models. Details I will be discussing in the upcoming slides. Now let's begin with the first one, that is the pharmacokinetic models. So in pharmacokinetic models, first we have the compartmental model. So compartmental model is the most commonly used pharmacokinetic models, and under this we are having first one, that is the one compartment model. So in one compartment model, what happens is whenever we are giving a particular drug, it gets absorbed into the entire body. That is, we are assuming that the entire body is accommodating the drug, and this distribution occurs rapidly. As you can see, after the administration, that is intravenous administration of a particular drug, this has spread into the entire body. So this compartment is basically a hypothetical one. It is not a physiological or an anatomical compartment. It is the compartment that is we are visualizing the whole body as a single compartment. So this is about the one compartment model. As you can see here by the diagram, that is drug dose is given into the compartment, and from that single compartment only the elimination of the drug occurs. The next is the two compartment model. So in two compartment model, whenever we are giving the drug, that is a intravenous route, here you can see it is given by the intravenous route. So initially, first it will go to the central compartment, that is basically comprising of the plasma and those organs which are highly perfused, that is here you can see the lungs, kidney, heart, because these are the organs which are highly perfused. So first it will be distributing rapidly into these organs, and then later on it will be distributed into the rest of the body. That is, the equilibrium occurs with the other tissues later on. So this is a two compartment model. As you can see here, intravenous administration is done, then it reaches the central compartment, which is the plasma or the highly perfused organs, and from there it goes to the peripheral compartment. In peripheral compartment, we are having the organs which are less perfused. It can be fat cells or it can be the bones. And here also the elimination occurs from the central compartment. So the important thing which we have to remember is elimination occurs always from the central compartment. In case of one compartment model, there is no reason for having a central compartment because it is only a single compartment, that is entire body is visualized as a single compartment. Now let's discuss about the graphs which we obtain in the different types of compartment model. And basically the purpose of modeling is, first we are validating the models, that is we are taking the different blood concentrations, and then we are trying to find out it belongs to which type of compartment model. And once we are sure that this particular drug follows this particular compartment model, then we can get the values for the concentrations which we have not even observed, that is with the help of the statistics and with the help of the graph. So first we have one compartment model for IV bolus. So here you can see the concentration is present in the y-axis and the time is present in the x-axis. So whenever we give a drug by IV bolus route, what happens is initially the concentration of the drug will be maximum, that is in the blood, and slowly it will be decreasing because it is getting distributed or metabolized. So this is very simple. This is one compartment model, and when we do the log of the concentration, it becomes a straight line with a downward slope. Then if a particular drug is given by extravascular route, that is not the intravascular route, and the compartment model is one compartment model, so initially what will happen is there is increase in the concentration slowly, that is it is not in the blood, so the drug slowly enters into the blood. So as a result, you can see log C, this is the log C in the y-axis, it slowly increases, and once after reaching the maximum, then it will start decreasing with a negative slope. This is because then it is getting distributed or metabolized. So this is the one compartment model for extravascular route of administration. Now, what will be the difference between one compartment model and two compartment model? As you can see clearly from the graphs here, that in two compartment model, we will be having two different slopes, whereas in one compartment model, we are having a single slope. Like here it is clearly seen is a single slope. Here also you can see the single slope. Here also it is following one particular pattern, one curve. But here you can see it is having two different patterns. So when you are giving IV bolus and the drug is following the two compartment model, initially the first part of the slope, the concentration is maximum initially, and the first decrease in the concentration is actually dedicated to the central compartment, as I have already mentioned, the central compartment. And then later half, because it is getting distributed from the central compartment to the peripheral compartment, and as a result now this distribution will be comparatively slower because of the point of reaching the equilibrium between the central compartment and the peripheral compartment. So this is basically due to the distribution to peripheral compartment. Now when we do the log concentration model, it will be in this way, that is we are having two slopes, both are downward slopes. And now when drug which is given by extravascular route and it is a two compartment model, it is very similar to the one which we have seen in one compartment model. Initially the concentration of the drug increases, as you can see here, concentration is on the y-axis, and once it reaches the maximum, then first there will be a rapid fall because of the distribution of the drug fastly from the central compartment, then slowly reaching equilibrium by distributing to the peripheral compartment. So here we are getting two downward slopes, two different slopes, but here we are getting a single slope. Here also single slope, but here we get two different slopes. So I hope it is clear. That is, in one compartment model, we have to remember there is a single slope, whereas in case of two compartment model, there will be two slopes. First for the initial central compartment, and slowly the distribution process becomes slow because of the state of reaching at equilibrium with the peripheral compartment. As a result, the decline will become slow. So that's why we are getting the second slope. So two slopes in two compartment model, one slope in one compartment model. Now coming to the multi-compartment model. So multi-compartment model means comprising of more than two compartments. So here we are visualizing the body to have more than two compartments. That is, body is considered as more than two compartments. So under this we are having two categories. First is the catenary model, and then we have the mammillary model. Okay, so mammillary model is the model which is most commonly followed for the multi-compartmental models, and catenary model is comparatively less followed. And the difference between two is clearly evident from this image. As you can see here, in mammillary model there is a central compartment. Okay, from central compartment it will be going to two different peripheral compartment, and there will be equilibrium between two different peripheral compartment, and these two peripheral compartment are not connected to each other. They will be only connected to the central compartment. But in case of catenary model, here you can see the drug is administered into the central compartment. From central compartment, it is going to one peripheral compartment, that is the compartment number 2. From that peripheral compartment, is going to the third peripheral compartment, that is the compartment which is even less perfused. So in this you can see there is a series, and these two peripheral compartments are actually connected to each other. So it looks like the links of a train. So this is the model in which the compartments are connected in series. That is, not all the peripheral compartments are connected to the central compartment, whereas in case of mammillary model, all the peripheral compartments are connected to the central compartment. So this is a major difference between mammillary model and the catenary model. So this was about the multi-compartment models. Now coming to the next one. So the assumptions which we do when we are actually following the compartmental concept, that is we are doing the compartmental pharmacokinetic modeling. So first assumption, the most important assumption, is that the human body is made up of hypothetical compartments. I mentioned it already. We divide the human body into several compartments, and these compartments are neither anatomical and nor physiological. These are hypothetical compartments. Okay, the next thing is the drug is distributed uniformly throughout all the compartments which we visualize, and the elimination occurs only from the central compartment. Very important point. So three assumptions which we make. First is the human body is made up of hypothetical compartments, then the drug is distributed equally and uniformly throughout all the compartments, and the elimination occurs only from the central compartment. Now how do we assign different organs and tissues into different compartments? So that is what we call as allotment. So in central compartment, as I have mentioned already, it will be including blood, that is plasma, and the well perfused organs. So well perfused organs are those. What are those well perfused organs? First is liver, then we have lungs, then we have kidney, and then we have heart. So all this can come under the central compartment, and then we have the peripheral compartment. In peripheral compartment, we have the organs which are poorly perfused. Those includes skin and bones. So these are the two compartments. Then one special case for brain. So brain can be either a part of central compartment or it can be a part of the peripheral compartment, but it depends upon the drug which we are giving, the pharmacokinetics of the drug which we are studying. So suppose if the drug is hydrophobic in nature, that is, it is lipophilic, it means it can easily cross through the biological membranes, and as a result the drug can easily enter into the brain by crossing the blood-brain barrier. So in that case, brain will be coming under the central compartment. But if the drug is hydrophilic, that is, it cannot cross the blood-brain barrier easily, that is because it cannot pass through the biological membranes. So in that case, brain will be a part of peripheral compartment. So this is the distribution of the organs and the tissues into different compartments. So with this, we are ending the compartmental model of pharmacokinetics. Now coming to the next, pharmacokinetic model, that is physiologically based pharmacokinetic modeling. So it is basically an extension of the compartmental model. Here what we do is we consider each and every organ and tissues of the body as a single compartment. So we are having several compartments and we are going to find out the pharmacokinetic parameters for each and every compartment. So it is basically mathematically it is describing relevant physiological, physiochemical and biochemical processes that influence the pharmacokinetic profile of a drug. And here the factors that mainly affect the absorption are of primary concern. This model, that is PBPK model, that is physiologically based pharmacokinetic model, is used for calculating the first in human dose, that is the first dose which we are giving to the human in the clinical trials after getting the data from the preclinical trials. And it also helps us to study the drug-drug interaction. And since here we are dividing the body, that is here we are considering the body is comprising of several compartments, each and every organ and tissue is considered as a single compartment, so the process becomes very complex, and as a result this leads to increase in cost and it leads to the consumption of time for doing the modeling, that is for doing the pharmacokinetic modeling. But it is actually more physiological because here we are considering each and every organ as a separate compartment. So this was about physiologically based pharmacokinetic modeling. Then we have the non-compartmental analysis. So from the name it is clear, that is here we are trying to obtain the data for the pharmacokinetics, that is the different pharmacokinetic data, without considering the compartmental models. That is, we are not considering the body as a particular compartment at all. Here you can see, without deciding on a particular compartment model. So where do we need non-compartment analysis? So non-compartmental analysis is required in the conditions like if we are trying to find out the pharmacokinetic parameters in neonates in animals. And why is it that? This is because when we are trying to get the plasma concentration, we need to take multiple samples of the blood so that we can plot the graph. But in case of neonates and animals, if we try to take multiple samples of the blood, then it can lead to severe blood loss because already they are short of blood. So because of this reason, we cannot apply the compartmental model in case of neonates and in case of animals because there is a risk of blood loss. So we need to go with the non-compartmental analysis. Next is when the drug which we are studying follows different compartment models in different individuals, because suppose if a drug is following one compartment model in a particular individual, but when you give the same drug to some other individuals, there it is following the two compartment model, somewhere it is following the multi-compartment model. So in that case we cannot have a compartmental model which is going to characterize the pharmacokinetic parameter of that particular drug. So in that case also we are going to use the non-compartmental analysis model. And what is the main parameter which we see here? That is mainly the AUC, that is area under curve. So here you can see a drug is given in the initial phase. When the absorption occurs, you can see the slope going upward, then elimination occurs, and then finally it is reaching the lowest concentration. So in this graph we need to know the area under curve. Okay, so this area under curve is responsible for making us understand about the overall drug exposure which has occurred. And then we can also find several other parameters like Cmax, that is the highest concentration of the drug in the blood. Then T half, it is the time which is taken to reach the half of the concentration which was the maximum concentration, like that is half of the Cmax. And then C minimum means the lowest concentration of the drug which is seen in the blood. So the main parameter which we need to find out is AUC, that is area under curve, in case of non-compartmental analysis, and it is applied in case of neonates, in case of animals, in case the drug is not following the compartmental model, same compartment model in different individuals. So this is about non-compartmental analysis. Now finally coming to the statistical models. So statistical models is based on the calculation and statistics complicated mathematical formulas. So it accounts for variability, that is inter-individual variability, that is the pharmacokinetic variability which occurs from one individual to another, then intra-individual variability at different state of the individual, whether the person is having a particular disease in a different disease state, in a physiological state, and then unexplained variability, that is residual unexplained variability. The advantage of statistic model is that it can even find out the pharmacokinetic parameters with the help of just small amount of data, that is the sparse data. Little bit of data is also enough for the statistical model to predict some of the pharmacokinetic parameters. Then it also includes the several covariates. The covariates which are actually going to influence the pharmacokinetic parameters. Like as we have already seen, the absorption can be affected by different types of food substances which we are consuming when we are taking it by oral route. Then there are several processes which are affecting the distribution, which are affecting the metabolism. So all those things will be considered in the statistical model. And the main thing which the statistical model does is it also helps us in finding out the population pharmacokinetic parameters and the individual pharmacokinetic parameters. So compartmental analysis, it is done for mainly individuals, but this helps us to take into account the population as a whole. So this is the advantage of using the statistical models, which is using the complicated statistics and the mathematical tools. Now coming to the PD models, that is pharmacodynamic models. Under that, the first classification, the broad classification, is simple steady state models. Okay, that is steady state concentration and simple models. So under this we are having several types of model. First is the fixed effect model. So it is also known as the quantile effect model. So it is very easy to understand. That is, in this we are looking for the concentration of the drug, and when a particular concentration of the drug is reached, then we will get a predefined effect. That is, we will look for the presence or absence of a predefined effect at a particular concentration of the drug in the blood. As you can see here, fixed effect, that is to be present or absent at a particular drug concentration, and it is predefined. So if the concentration has reached that particular area or it has gone above that particular value, then only we will be getting the particular effect. So one example of fixed effect model is the threshold model. So threshold model, here you can see the example. The autotoxicity which is occurring during gentamicin therapy, that is with trough levels exceeding 4 microgram per ml for longer than 10 days of therapy. So this is the threshold. It has to cross this threshold, then only we are going to get the autotoxicity. So it is easily explained by the equation as you can see here. That is, effect is equal to the fixed effect, which we have already decided, when the concentration is above the threshold concentration. So we will get the effect, which is the fixed effect, only when the concentration is more than the concentration threshold. So E is the measured effect and C is the measured concentration. So this was about the fixed effect model. Now coming to the next one, that is the linear model. So in linear model, what we say is the effect of the drug is proportional to the concentration of the drug which is present in the plasma, and as a result we get the equation of E equals to M into C plus E naught. So what is E here? E is the effect which we will be finding out. C is the concentration of the drug. M is the slope of the effect to concentration graph, that is effect versus concentration graph, and E naught is the effect which is present at the baseline concentration. That is, here you can see E naught. Okay, E naught is basically this value. So this value means this is the effect which is present even at zero concentration of the drug, and this keeps on increasing. We are having the slope here. That slope is nothing but M, that is the proportionality factor. So we get this equation, that is E equals to MC plus E naught. So this is the equation for the linear model of pharmacodynamics. So one such example of the drug which is following the linear model of pharmacodynamics is the salivary flow rate after the plasma concentration of pilocarpine infusion, because the pilocarpine is a cholinergic drug and it is causing the salivary secretion. So this effect can be studied by this linear model. Now, one disadvantage or the limitation of linear model is that it is usually applicable only at low concentration of the drug. That is low concentration, that higher concentration of the drug we cannot apply the linear model of pharmacodynamics. Now coming to the next one, that is log linear model. As you can see here, in log linear model we are actually getting a little bit of sigmoidal type of graph. That is, here you can see initially when we increase the concentration, here we are having log C and here we are having the effect in the y-axis. Initially when we are increasing the concentration, the effect increases slowly. Then later on, for the next 20 to 80% of the maximum effect, the maximum effect is this one. This is the maximum effect, that is Emax. For 20 to 80% of the maximum effect, there the relation is just like that of the linear model. That is, here we are having a slope. Okay, and then later on, once this area is crossed, then whenever we are increasing the drug, the effect is increasing very slowly. So that's why we are getting a sigmoid shape graph, that is in 20 to 80% of the maximum effect range, model will be following, actually it will be reducing to the linear model. And what is the equation for log linear model? That is E equals to M into log C plus E naught. That is E naught is the baseline effect, that is the effect which is present at zero concentration. So E naught is nothing but the baseline effect, that is initially, and M is the proportionality factor, and then we have log C, that is C is the measured concentration, then E is the particular effect which we will be deriving from this formula. So one example where we can use this model is the correlation of the prothrombin activity with the plasma concentration of warfarin. But there is a big limitation for log linear model, as you can see from this equation. That is, when the concentration of the drug is 0, then we will get M into log 0, and log 0 is undefined. That is the reason why we will be not able to find out the effect when the concentration of the drug is 0, that is 0 concentration. In that case, because of the logarithmic function, we will not be able to find it out. So this is one disadvantage or the limitation of the log linear model. Now coming to the next one, that is Emax model. So in Emax model, the equation is as follows, that is E, that is the final effect, is equal to the baseline effect, that is E naught plus Emax, that is the maximum effect, into the concentration of drug divided by EC50, that is the concentration of the drug which is responsible for producing half of the Emax, that is Emax by 2 plus the concentration. So here you can see, here we will get a hyperbolic type of graph. So we have concentration on the x-axis and we have effect on the y-axis, and we get a hyperbolic curve. And Emax is this one, that is the maximum effect, and this is the half of the maximum effect. So the corresponding concentration will be EC50. And this model is actually derived from the receptor theory. That is, when a drug binds to the receptor, it forms a drug receptor complex which is responsible for the effect. It can be represented easily by this formula, that is dr concentration, that is R total into drug by the KD plus drug. So here, what is this R total? R total is actually referring to the number of binding sites in the particular receptor, and KD is basically the concentration at which the half of the effect is seen when we are comparing this with the particular equations here. So this is about the drug receptor theory, which is very much similar to the Emax model. So example of the drugs which are actually studied with the help of this Emax model of pharmacokinetics includes the propranolol plasma concentration, okay, and its result, that is decreasing in the heart rate. So decrease in the heart rate with the propranolol plasma concentration is evaluated with the help of this Emax model. And Emax model is also having some limitation, that is the maximum effect of highly potent drugs cannot be found. And why is it so? This is because when we have a highly potent drug, so even before the maximum effect, suppose let us see, this is the maximum effect, this is the maximum, even before the maximum effect is reached, it will have toxicity, and this will lead to the death of the organism in which we are checking that particular drug, that is in the preclinical trial. Or there can be another disadvantage also. Suppose this Emax is attained very slowly, that is it takes a lot of time to attain this Emax, that is the maximum effect. In that case, it will delay our study for a longer period of time. So that is also a disadvantage of this Emax model of pharmacodynamics. Now coming to the next one, that is sigmoidal Emax model. So sigmoidal Emax model was given by Hill, and here we have the effect, that is effect is equal to the baseline effect plus Emax into C to the power n by EC50 plus C to the power n. Emax is the maximum effect, EC50 is the concentration at which we get the half of the maximum effect, and n is the number of the drug molecules which are bind to the each receptor molecule, okay. So the number of drug molecules which are binding to each receptor molecules. So here you can see we will get a sigmoid shape of curve. So here we are getting sigmoid shape curve, and based on the value of n, the shape of the curve changes. So when the n is equal to 1, okay, this is a special situation, n is equal to 1, in that case what will happen is this will turn into 1, this will turn into 1, and as you can see now it has reduced to Emax model formula. So sigmoidal Emax model becomes the Emax model when n is equal to 1, that is the number of drug molecules that combine with each receptor becomes 1. So in that case it reduces to the Emax model, and when n is more than 1 then we are having a slope, that is it goes upward, and if n is less than 1 then it will go downwards, that is concentration is seen here, and on the y-axis we are having the effect. So the disadvantage of sigmoidal Emax model is that it considers that a particular drug is having mechanism of action in which it is going to act only from one receptor. So in that case, it is not considering multiple mechanism of action of a particular drug, and it is also considering that the effect of some of the drugs get saturated, that is when the receptors are occupied, but it is not true for all the drugs. An example of the drugs for which we are studying the pharmacodynamic parameters with the help of sigmoidal Emax model includes the antiarrhythmic activity of tokenite, that is antiarrhythmic activity of tokenite with the concentration of the tokenite. Now coming to the next set of PD models, that is pharmacodynamic models, that is advanced non-steady state models. So under this we are having different models. First is the biophase distribution model, then we have the signal transaction model, then we have tolerance model, then we have indirect response model. So when are we going to use advanced non-steady state models? From the name itself it is clear, that is when we are having non-steady state plasma concentration we are going to use these type of models. So the effect of the drug is not immediate. In the previous type of models what we are seeing, that whenever the drug is reaching a particular concentration, it is showing the particular effect then and there itself, and the distribution of the drug gets easily done. But here the distribution of the drug is the rate limiting step, and there is a slow association and dissociation of the drug with the receptors. Earlier it was not the case in case of the simple steady state, but here in advanced non-steady state there are several limitations because of which the advanced non-steady state model is being used. That is, the effect of the drug is not immediate, then the next thing is distribution takes time and it is a rate limiting step, then we have slow association and dissociation of the drug from the receptors. So now let's discuss all the four models one by one. First is the biophase distribution model. So before we discuss what is this biophase distribution model, we need to know what is this biophase. So biophase is basically the effect site, that is the site of action of a particular drug. So from that only we can understand what is meant by biophase distribution model. So what happens is, for some drugs the pharmacological response which is being produced is usually either before or after the plasma drug concentration has peaked. Means the peak of the plasma drug concentration and the peak of the effect will not coincide, and this is the case when we are using the biophase distribution model, which is because it takes time for the drug from the plasma concentration to reach the effect site. And here whenever we are measuring the concentration, we are measuring the concentration in the plasma and not in the effect site. So this can be bridged with the introduction of a hypothetical effect compartment. As you can see here, the concentration in the plasma, and then the effect is mediated how? That is, in the concentration in the effect compartment is the one which is responsible for producing the effect, not the concentration in the plasma compartment. That is the reason why we introduce this effect compartment, which is a hypothetical compartment, and it is a pharmacodynamic compartment. And this effect compartment was actually postulated by Holford and Shaner. These are the scientists who actually recommended the effect compartment. So effect compartment is not a part of the pharmacokinetic model, but it's a hypothetical pharmacodynamic compartment. So the different types of drugs for which we are doing the pharmacodynamic modeling by the biophase distribution model includes midazolam, then we have pancuronium, and then we have alprazolam. So these are the drugs whose pharmacodynamics is monitored, or like it is evaluated with the help of biophase distribution model. Then next we have the indirect response model. So in case of indirect response model, we are considering the particular fact, that is the drug response is actually indirectly mediated by either inhibition or stimulation of the factors which are responsible for production or dissipation of the response. So let me explain it in clear terms. Like here you can see the image, this is the response. It is actually produced by some of the processes, like some of the processes which are producing this response and some of the processes which are abolishing this response. So some of the drugs act by either stimulating or inhibiting this production process, or some of the other drugs either stimulate or inhibit this process, which are actually abolishing the response. So in that case, we are using the indirect response model for doing the pharmacodynamic characters and the parameters of that particular drug. Example is warfarin, because it is acting indirectly on the coagulation profile with the help of the prothrombin activity, that is, it is affecting the prothrombin activity. Next is H2 receptor antagonist, that is, it is used for peptic ulcer disease, that is because it indirectly affects the gastric acid secretion by binding to the H2 receptor, not directly. So this is about the indirect response model. Now coming to the next one, that is the signal transduction model. So in signal transduction model, we will come across the two different receptors which are most important, that is the cell surface receptor, and then we have the nuclear receptor and the cytosolic receptors. So we have two types of receptors. First is the cell surface receptor, then we have the cytosolic receptor and the nuclear receptor. And signal transduction model is basically considering all the steps which are responsible for mediating a particular effect of the drug. That is, normally in the effect of the drug, we don't consider these steps, like we don't give a value to these steps, like the activation of the receptor, then how the signals are being carried down, in how the second messengers are formed. So this model will take into consideration all those receptors and the second messengers, and as a result we can see that there will be a delay in the effect, because there are several cascade of steps which are responsible for producing that particular effect. To characterize such delayed effects, we use stochastic models. So stochastic models is nothing but opposite are the deterministic models, because in this we need to have a range of outcomes, because we are not considering the processes which are occurring behind the scenes. So we are considering a range of outcomes, and each outcome will be having a different probability of occurring. So this is the reason why we are considering stochastic models to actually characterize these delayed effects because of the signal transduction process, that is the propagation of the signal once the drug binds to either the cell surface receptor or to the cytosolic receptor or to the nuclear receptor. So this was about the signal transduction model. So under this we can actually consider some of the hormones and their effect, because in case of hormones we are having the receptors, they bind to the receptors, and then it leads to a cascade of steps which is actually mediating the pharmacological or the physiological effect. So in that case we can use the signal transduction model. Then next, coming to the next one, that is the tolerance model. So what is tolerance? Tolerance is basically defined as reduction in the pharmacological response after doing repeated or continuous drug exposure. So here the concentration of the drug remains same, but the effect which was earlier produced is not seen now. So you can see the PD parameters, that is Emax and EC50, that is the concentration which is producing the half of the maximum effect, actually varies, but the concentration of the drug at the effect site remains the same. Here you can see in the graph. So pre-chronic exposure of that particular drug and post-chronic exposure of that particular drug. Here we have the effect and here we have the dose. So pre-chronic exposure, you can see at the particular concentration, that is at the particular dose, that is it is producing a higher effect. Okay, so the effect is more compared to the condition when the particular drug is given after a post-chronic exposure. So here you can see the graph has actually shifted downwards. So this is the case of tolerance. And why does tolerance occur? We have several theories. Out of that, the most common one is the receptor pool depletion. So there is a decrease in the receptors where the drug binds, or it can be also decrease in the receptor affinity for that particular drug. So these two can be the reasons for the development of tolerance, and we need to consider this tolerance in mind, because it can lead to poor clinical outcome, because we might be giving the same dose of the drug thinking that it will be producing the same effect as it was producing earlier, but by the time we are giving the drug for a continuous period, that is we are giving the same drug continuously, it will lead to the development of the receptor desensitization, that is decreasing the receptor pools, or it can decrease the receptor affinity for the drug, and this will lead to the production of decreased effect, which is not sufficient enough to provide the beneficial effect to the particular person. So this can lead to the development of poor clinical outcome. One such example is increase in EC50, that is the concentration which is producing the half of the maximum effect over time for terbutaline. Now coming to the final one, that is the PKPD modeling. So PKPD modeling is nothing but the integration of the pharmacokinetic model and the pharmacodynamic models, and here we are considering mainly 4 different attributes which differentiate between the different modeling concepts. First is the link between the concentration and the response mechanism which is responsible for producing the observed effect, that is the concentration and the response mechanism which is accountable for producing the particular observed effect. So based on this, we can classify the PKPD models into direct and indirect link PKPD models. Then next is based on the response mechanism by which the effect is mediated. In that case, we can classify the PKPD models into direct and indirect response models. Okay, that is based on the response mechanism which is producing the effect. Then the first one was concentration and the response mechanism which is responsible for producing the observed effect. Then we have the other attributes, that is information which is used to relate the concentration to effect, that is concentration is related to effect or concentration and effect both are related to each other, that is whether it is a bidirectional or a unidirectional flow of relations between the concentration and the effect. In that case, we have 2 different types of models, that is hard link and soft link models. Then based on the time dependency of the parameters which are used in pharmacodynamic modeling part of the PKPD model, so in that case we will have 2 types of model, that is time variant versus time invariant PKPD model. So coming to the first category, that is the direct link versus the indirect link models. So in direct link model, what happens is the measure concentration in the plasma, that is the measure concentration of the drug in plasma, is directly linked to the effect site concentration. So it means that particular concentration in the plasma will be producing the effect very quickly, that is the equilibrium between the concentration occurs rapidly, that is in between the plasma and the effector site. So the concentration which we get in plasma, when it is peaking, at that moment only we will get the peak of the response also, that is the peak of the effect. As you can see here, the concentration and the effect maximum, that is maximum concentration and maximum effect, would occur at the same time and there will be no hysteresis. So hysteresis, I will come into this term in the upcoming slides. So hysteresis is basically a lag between the concentration and the effect, that is when the maximum concentration is there, the effect should be maximum, but sometimes what happens is the concentration has reached the maximum but the effect has not reached the maximum of its potential. So that is what we call as hysteresis, and there can be 2 different types of hysteresis which I will be discussing. In this image you can see the PKPD modeling, that is the direct link model, that is here the pharmacodynamic part is actually considered to be done with the help of Emax model here, and the concentration which was seen in the plasma is just the same as the effect site, and the effect maximum and the concentration maximum both has occurred at the same time. So that is the reason why it is called as the direct link model. One example for the direct link model is the analgesic effect, which we quantify with the help of the visual analog scale, which is nothing but a scale for pain rating to the concentration of diclofenac in plasma. So there is one example of the direct link models, that is direct link PKPD models. Next, coming to the next one, that is the indirect link model. Indirect link model comes into play whenever we are having hysteresis. Okay, so we have hysteresis, means in that case we will have to use the indirect link model. So this indirect link model is required only when there is a temporal dissociation between the time process of the concentration and the effect. Okay, that is the concentration and the effect maximum are not matching each other. That is what we call hysteresis is seen in case of the concentration effect relationship, and it is basically due to the distributional delay, that is from the plasma to the effect site. So wherever we are having an effect compartment, you remember I have already discussed this earlier, the introduction of the effect compartment which was done by Shaner and Holford. So whenever we are having the effect compartment, in that case it will be following the indirect link PKPD modeling. As you can see here, first pharmacokinetics, it is seen in the plasma compartment, that is the concentration in the plasma compartment. From there it is related to the effect compartment, which is a hypothetical pharmacodynamic compartment, and from there we are getting the effect, that is effect which is proportional to the concentration which we feel is present in the effect compartment. So in this case it is an indirect link PKPD model. So requirement of effect compartment, whenever there is a requirement of effect compartment to justify the pharmacokinetic and the pharmacodynamic relations, then we will apply the indirect link model. And hysteresis is basically the lagging of the concentration and the effect, that is the maximum concentration and the maximum effect are not coinciding with each other, and this hysteresis actually leads to the formation of a looped graph. It can be like this or it can be like this also. So that is what is called as the hysteresis loop. So we have different types of hysteresis, that is the clockwise hysteresis, and we have the anti-clockwise, that is the counterclockwise hysteresis. So clockwise hysteresis, you can see it is going in this way. So what happens is there is a decrease in the effect, that is from E2 to E1, as you can see, with passage of time. And you can see at a particular concentration we are having two different effects. So this concentration is not the concentration of the effect site, this concentration is the concentration of the plasma which is coming into equilibrium with the effect compartment, which is a hypothetical compartment. So as you can see, with the passage of the time there is decrease in the response in case of clockwise hysteresis. So example of the drugs which are showing clockwise hysteresis includes fentanyl and alfentanil. So the reason behind this is these drugs initially gets absorbed into the circulation very fast. Then because of that they will be having the maximum effect, that is the Emax, and then after that these drugs from the circulation gets distributed to other tissues. So because of this distribution, later on the concentration will decrease, and as a result the effect will also decrease, that is E1 is very much less compared to E2. This is the reason why we get clockwise hysteresis in case of the drugs like alfentanil and fentanyl. So the next one is the counterclockwise hysteresis. As you can see here, with passage of time there will be an increase in the effect. So here you can see the E2 is reached later, so E1 has reached earlier, so E2 is far much better than E1. So there is an increase in the response with time, and it is seen in case of the drugs like morphine, which is an analgesic. So what happens is initially morphine slowly reaches the plasma. Actually the morphine is present in the plasma, and from there it is slowly going into the central nervous system. So when it is going from the plasma to central nervous system, it takes time, and because of that where the concentration in the central nervous system is initially low, so initially the effect will be low. But as soon as most of the drug has entered inside the CNS, then the effect is increasing rapidly, because now the drug is inside the central nervous system, and that is the place where it is going to act to produce the analgesic effect. So this is the reason why we get anti-clockwise, that is the counterclockwise hysteresis in case of morphine, that is the response increases with increase in time because of the drug entering in more concentration in the central nervous system. Now coming to the direct response versus the indirect response models. So dependent on the involved physiological mechanisms, the expression of the observed effect might either be directly related to the concentration at the effect site, or it might be secondary to the several intermediary response steps. So indirect link and direct link model both can come under the direct response model, because here the effect is actually produced by the concentration of the drug which is present in the effect compartment, or it is present in the plasma concentration. There is no intermediary steps in between that. So in that case, what we will do, we will consider the direct response model. So for direct response model, the observed effect is determined by the effect site concentration only, because there is no time lag only. So it is not involving any sort of delay. Basically, there is no delay between the concentration which is responsible for producing the effect, that is in the effect compartment, or maybe it is in the plasma in case of direct link model. So both direct link model and indirect link model can come under the category of the direct response model. Next, we have the indirect response model. So in indirect response model, apart from the distributional process, that is the distributional delay, there can be also temporal dissociation between the time course of the concentration and the effect. And this is because of the presence of the intermediary steps of the effect. So in that case, we are going to do indirect response PKPD modeling, and it was first used for the anticoagulant warfarin, that is mediating its effect by acting on the prothrombin complex. Then other examples include muscular response in patients with myasthenia gravis, which is being treated with the help of pyridostigmine. So pyridostigmine is acetylcholine esterase inhibitors. So indirectly it is going to increase the concentration of the acetylcholine, thus it will produce the desired effect. So it can be used, this method, that is the indirect response model, can be used in cases where the effects are actually mediated by the genes also, that is gene mediated effects. That is, there is no direct effect, in between there are intermediate steps. So in that case, we can use this model, that is the indirect response model. Now coming to the next variety, that is the soft link versus the hard link models. So soft link is very simple, that is we are having a bidirectional relationship between the concentration and the effect. That is, there is bidirectional flow of the information, that is concentration related to the effect, then effect is also related to the concentration. So we will be using the information obtained from the concentrations also, and also from the effect. And hard link model is basically, we are going to include the information, that is unidirectional flow of information, that is we are mainly going to consider the concentration only, that is responsible for producing a particular effect. So here we will take other data from the in vitro studies, like the receptor affinity, then we have the other data, like we have the minimum inhibitory concentration in case of antibiotics. So these will be taken into consideration, and we will actually predict the effect here. So that's the reason why we are saying here that hard link models are actually having a predictive character, and they allow the forecast of the pharmacodynamic activity of the new compounds. That is, we will take only the concentration into account, plus the different pharmacodynamic parameters which we are getting from the in vitro studies, like the receptor affinity studies. Then other things include minimum inhibitory concentration and all, and with that we will predict the effect. That is, we will not take into the consideration the effect and the concentration both together, but we are going to predict only the effect from the concentration. So in that case, it is called as the hard link model, that is unidirectional flow of information. Whereas when we take both concentration and effect into consideration and both are being related, then in that case it is a bidirectional flow of information, which is known as the soft link models. Now coming to the final categorization, that is time variant versus time invariant models. So the drugs which we are using will actually follow the time invariant models, because time invariant models says that the effect remains the same at a particular concentration even though it is given at different times. But when the effect varies, that is at the same concentration at different times, but it is going to show different effect, that is, in that case it is called as the time variant model, and it is either due to the development of tolerance, or it can be due to the development of sensitization. These are the two things which are responsible for creation of the time variant pharmacodynamic response related to a particular concentration. That is, the concentration remains the same, but the effect either decreases or increases. So what are the reasons for those? So the reason is basically tolerance, and then we have sensitization. So here you can see we are having the Emax model, but the effect, it is actually varying from time. That is, tolerance occurs when we are giving repeatedly a particular drug, that is continuous exposure of a particular drug, there will be decrease in the receptor pool, there will be decrease in the affinity of the receptor to the particular drug, and as a result tolerance can occur. Then sensitization can also occur, that is there is increase in the affinity of the receptor towards the particular drug. So in that case sensitization occurs. There also it will lead to an increase in the response of the drug compared to the concentration, that is the concentration which was present earlier is present now also, but the response has increased drastically, that is at different times. So in that case it is called as sensitization. When the response decreases, in that case it is called as the tolerance. So these are the two different time variant models. Now finally coming to the applications of the PKPD modeling, it includes population PKPD modeling, then we have other applications like drug development, then we have dosage regimen optimization, interspecies extrapolation, and extrapolation of the in vitro to in vivo studies about the pharmacokinetic and the pharmacodynamic parameters. Then we are having the selection of antibacterial agents. Then we can also study the drug-drug interactions. So coming to the first one, that is the population PKPD modeling. So in population PKPD modeling, we are going to find the parameters, that is the pharmacokinetic and the pharmacodynamic parameters in a population, not an individual, and it is going to follow the non-linear mixed regression model. Non-linear mixed regression model, that is the mixed effects regression model. So what does it means? That is the relation between the two variables which we are studying here will not be linear, that is it will not follow that slope method, that is E equals to mx plus c. Then it can be a mixed effect model, that is it will have both fixed effects and it will also have varying effects also. So both will be seen. That's why it is called as mixed effects regression model, and it was introduced by Scheiner, and it is meant for actually deriving the parameters, that is the pharmacokinetic and the pharmacodynamic parameters for the populations. So it provides us an opportunity to find out the inter-individual variability in different pharmacokinetic and the pharmacodynamic parameters. So this is about the population PKPD modeling. Then next is drug development. So PKPD modeling is actually followed by several industries for the development of the new drugs. This is because a particular concentration of the drug which is present in an animal, and if it is producing a particular effect, that same concentration will be also producing the same amount of effect in the humans. That is the normal thing in most of the cases. Only thing is the dose which is actually leading to that particular concentration in the animals will not be the same for the human beings. So that is what which we are actually changing from the preclinical models to the clinical models, and we are actually developing such models in which we can easily extrapolate the animal data to the human species, and because of that it will actually hasten the process of drug development. Mainly we are using it in the phase 1 dose escalation studies, okay, in phase 1 dose escalation studies, and it will provide us the information which will help us to design the subsequent stages, that is the subsequent phases in the clinical trials for a particular drug development, that is before we are recruiting a large number of individuals. So this decreases the drug development cost and time drastically. That's why PKPD modeling is actually referred to, and it is used in case of drug development. Now coming to the next application, that is dosage regimen optimization. It is very clear. It is actually a part of the drug development itself. So rational dosage regimen can be found, and it can be clinically tested in clinical trials, and we can see the variability in effect and time, that is effect versus time relationship can be predicted with different dosage regimens, okay, and different dosage regimen scenarios also. So next is interspecies extrapolation. So the models will mainly account for the pharmacokinetic parameters, because the pharmacokinetic parameters is the one which is maximally different in the different species. As you can see here, it varies from the species to species, but pharmacodynamic parameters are usually the same. Next is studying different drug interactions. Suppose when we are giving two drugs like triazolam and erythromycin, it leads to increased plasma concentration of the triazolam. So this will be also studied with the help of PKPD modeling. Next, we are having extrapolation from in vitro studies into in vivo studies. So what does it mean? That suppose if we found an efficacious concentration of the drug, that is it is either able to produce the inhibitory effect or it can produce the stimulatory effect, then we can find the corresponding dose which can be given to the humans to, or that is in vivo models for producing the same amount of effect. And this we can easily find out by putting the values into the equation, that is ED50 is equal to clearance into EC50 by bioavailability. That is ED50 is the dose which is responsible for producing the effect in at least 50% of the individuals who are getting the drug. Then CL is the clearance of the drug from the plasma, and EC50 is the concentration which produces the half of the maximum effect. And finally we have everything divided by bioavailability. So drugs which produce that particular effect in vitro model will be very much similar to the drugs which are producing the effect in the in vivo model. So the only thing that is in vivo model in human beings and other organisms is that there will be some of the binding to some of the proteins. So only those needs to be adjusted, and with that we can actually extrapolate the pharmacokinetic and pharmacodynamic parameters from in vitro to the in vivo models. Now next we are coming to the next application, that is the selection of the antibacterial agent. So for antibacterial agent, the most important pharmacokinetic and the pharmacodynamic parameters which are actually determining the antibacterial activity includes the area under the curve, then we have the maximum concentration, that is Cmax, and then we have minimum inhibitory concentration. You can see in this graph the first parameter which we can see. So the first parameter which we can see is the Cmax by MC. So this is the Cmax, that is we are having the concentration on y-axis and time in x-axis. So this is the Cmax. This concentration corresponding is Cmax by the minimum inhibitory concentration. So the minimum inhibitory concentration is already known, that is minimum concentration which is required for the inhibition of the bacterial growth. And then next we have AUC by MIC. AUC means the area under curve, which leads to the extent of absorption of the particular drug by the minimum inhibitory concentration. So these are the two parameters which are actually used and selected for finding out the antibacterial effect of the drug. As you can see here, the main driver for antibacterial effect is AUC by MIC and Cmax by MIC. So it was used in case of the drug like colistin, which was later on used for the treatment of the bacterial infection in the critically ill individuals. Also, the PKPD modeling helps us to find out the patterns of development of antibacterial or antimicrobial resistance against the mono and combination antibiotic therapy. Now coming to the extension of this application, so we can use in vitro biofilm models. So what is biofilm? So as you can see in this image, we are having some of the microbes, that is the bacteria. Let us take it bacteria which are present freely. Okay, and when they combine together and they form an extracellular matrix covering them, then that is what we call as a biofilm. So here you can see a life cycle of the biofilm formation. So initially we are having free floating bacteria. These are known as the planktonic cells. Then they get adhered to a particular surface, and then they start producing a biofilm, that is like an extracellular matrix, and the division occurs, and now you can see a well established biofilm. Then this biofilm breaks and some of the bacteria again comes out, and then this cycle repeats. So this is the formation of biofilm. So what happens is this biofilm is actually responsible for mediating the antibiotic resistance, and the parameters which we used for finding out the antibacterial effect of the drugs against the planktonic cells, that is single bacteria, will not be applicable in this case. So we cannot use the minimum inhibitory concentration, and we cannot use the minimum bactericidal concentration also. So what we have to use in case of in vitro biofilm model is MBIC and MBEC. So minimum biofilm inhibitory concentration, that is the minimum concentration which is required for preventing the further growth of the biofilm once it is establishing or inhibiting the formation of the biofilm. Next is minimal biofilm eradicative concentration, that is the concentration which is required in the minimum concentration which is required to completely eradicate a biofilm. So this biofilm can produce resistance by several methods. Can actually produce the resistance by decreasing the entry of the antibiotics, then metabolizing the antibiotics, decreasing the clearance of the microbes from the immune system. It also varies with the different aging of the biofilm. Then it also restricts some of the nutrients, oxygen supply, and other things to enter inside it, because it is an extracellular matrix protecting the group of bacteria. So this was about MBIC and MBEC. Then we have different infection models, that is animal infection models, which are useful for finding out the antibacterial efficacy of the novel antibiotics. So we have different types of animal infection models, and these animal infection models are actually simulating the pathophysiology of the infection in the patients. That is the pathophysiology of the particular disease against which we are trying to find out an effective antibiotic. So here also PKPD modeling is very important because it will help us to find out the different parameters, that is the pharmacokinetic and pharmacodynamic parameters, and hence progress on to the clinical phase of the development of the antibiotics. So variations in pharmacokinetics only is the one which is actually responsible for creating several differences between the humans and the other animal models in which we are studying it. So we have different types of animal infection models. In that, two most commonly used are thigh infection models, and then we have the septicemia models. The next thing is the mouse thigh infection model. So it is one of the most commonly used animal infection model for finding out the PKPD relationships of the antibacterial drug. So first what is done is the mice is rendered neutropenic, that is decrease in the neutrophils. It is done with the help of administration of cyclophosphamide. Okay, so cyclophosphamide is given, it is causing the bone marrow depression, that is bone marrow suppression, leading to the neutropenia. Once the mice is rendered neutropenic, then what we are going to do is we will give, that is we will inject log phase bacterial cells. Okay, log phase bacterial cells, that is the bacterial cells which are in the log phase of the bacterial growth curve, into each of the thigh of mice. Okay, and then the compound which we want to test, that is for the antibiotic, that is for the antibacterial efficacy, is administered over 24 hours, and the efficacy of the antibacterial agent is then commonly determined by subtracting the log of CFU, that is colony forming units per thigh, at 24 hours of the treated mice in which we have given the antibiotic, to the control mice at time 0 hours. Okay, that is log of colony forming units per thigh in case of the mice which is treated with antibiotics, to the log of colony forming units per thigh of the mice or mouse in which the antibiotic was not given. Here you can see the thigh is being looked for the presence of the different amount of the colony forming units, and it actually requires some of the processing also. Then we have the another one, that is the septicemia model, which is comparatively easy to do as compared to the mouse thigh infection model, because in this case we are going to find out the colony forming units directly from the bloodstream. We are not going to process the thigh tissue. Okay, so first here also the method is the same. First we will have to render the mice neutropenic by giving cyclophosphamide, that is for 3 days. Then after that we have to give intraperitoneal, as you can see here, intraperitoneal injection of 0.1 to 0.5 ml of log phase of bacterial suspension. Same thing, we have to give the log phase of the bacterial suspension, that is zero point 0.1 to 0.5 ml, given intraperitoneally in the mice. And after that we have to do the subcutaneous administration, or we can do the different methods of administration of the antibacterial which we are studying over a period of 72 hours. And in this model the endpoints are very simple. Either we can look for the morbidity, okay, or we can look for the bacterial load, that is the colony forming units which is present in the blood, by doing the blood sampling of the mice. Now finally coming to the involvement of machine learning for PKPD modeling. So in this we can easily understand that doing the PKPD modeling is a very complex and tough job, and it actually involves several statistical and mathematical formula. So we know the fact that the neural networks are actually responsible to handle different types of data very easily, and the work it can do is it can also work on the non-linear systems. So what we can do is these neural networks can be now used for extrapolating to the effect to the unseen dosing regimens, and under this we are having a recurrent neural network which is actually a part of deep learning, in which the machine thinks just like human, and it is having a promising effect in doing the PKPD modeling, and this will be the future of PKPD modeling in the upcoming few years. Then finally coming to the softwares which are used for doing PKPD modeling. So under this two softwares out of all this is to be remembered without any doubt. First is WinOnLin, and then we have Multi. So WinOnLin is basically the most commonly used software for doing the PKPD modeling, and it does the non-compartmental analysis, whereas Multi, it does the compartmental analysis. And then we have other softwares like non-mem, then excel mem, then boomer, then java graphic user interface for boomer, then we have topfit, adapt 2, and then we have biopack. So these are the different types of softwares which we can use for doing the pkpd modeling. Finally, coming to the key take home points which we need to know, first is the pkpd relationship is very important, and we need to know the difference, and we need to know the way how pharmacokinetics and pharmacodynamics is related, so as to optimize the dosing regimen and do the rational use of the drugs. And it is responsible for helping in the drug development because it predicts the drug behavior in humans based on the preclinical data, that is the data which we obtain from the animals. It also enables the simulation of the different scenarios, and as a result it helps in decreasing the in vivo testing, that is the cost and the time which is required in vivo testing can decrease because we are having several simulations. So this finally aids to save the cost and save the time also, and hence lead to an accelerated development of the drugs for particular diseases. It can be development of the antibacterials, or it can be development of other drugs for different diseases. So in this way pkpd modeling is very advantageous, and it helps in cutting short the price of the drug development and also the time which was required for doing the development of the drugs. So with this I would like to end this seminar. So these are the references which I have referred to for creating the slides, and I hope you like this presentation. So if you like my content, please do like, share, subscribe, comment, and also press the bell icon so as to get notified whenever I upload a new video. Thank you guys.